when we talk about addiction, it's as if people are addicted to one drug at a time or so. And I particularly wonder from Dr. Jha's talk, you talked a little bit about alcohol, mostly about tobacco. Are the effects for people with addiction, because they're often comorbid, they're drinkers smoke, smokers drink. How can you model this? Are there interactive effects? Are they simple additive effects? Or do you think it's important at all to model comorbidities when you do this kind of work?
Smoking and drinking do go together, as you've outlined, and in most populations. The epidemiological studies that I have mentioned take into account the other exposures. So these risks for smoking are adjusted for the risks of drinking. It does vary, however, by particular populations as to what the excess is. The alcohol binge drinking pattern that you see in Russia and selected other parts of Eastern Europe, and you might see in inner city populations, for example, in Latin America among men, and certainly you might see on the First Nations communities in parts of Canada. They will have different effects than the typical pattern of drinking modestly. And we've seen that in India in our own studies, that in the subset of men that have binge drinking, you do see higher risks, but those that are modest drinkers, meaning they might drink once or twice a week, their risk, particularly for ischemic heart disease, actually appear to be a little bit lower. Alcohol is a bit more complicated than smoking, but most of the careful studies have been able to tease out the effects. What does it mean in terms of control? Well, it means you really should be trying to address both exposures from a public health perspective. It does vary by disease, right? It'll also be on the subset of, for example, particular types of cancers, esophageal cancers, oral cancers, are greatly compounded by both. Ischemic heart disease, in modest doses of alcohol, might be protective, but not in binge drinking levels. And smoking, however, is going to be clearly harmful. So it's an argument I think you're making for really good epidemiological estimation to drive policy in most of these settings, which we still don't have.
I think there was another question here. Yeah.
Andrei Krasikov, Vancouver, Department of Medicine. First of all, my accent is Russian. And that's why, first of all, you definitely have a personality and color as a statistician. As a physician working during the Gorbachev time of prohibition, one of the things I definitely cannot say nothing wrong with statistics to showing drop in mortality during the prohibition time in the former Soviet Union. But as a practicing physician living in former Soviet Union at that time, what we saw, there was a dramatical increase of poisoning and death from methanol, acetone, products of gasoline, whatever were able people to find, particularly young people and adolescents. There was a dramatic increase in mortality from drinking of horrible things. And that's why it's interesting what we're talking about, implementation of some kind of measures to prevent one thing sometimes looks like we're definitely overkilling. And another actual aspect, at the time of Gorbachev, bottle of vodka, you can build a house, you can change the thing in a kitchen. It was a really currency for many, many people who didn't drink. But statistic was interesting with respect of effect of mortality of society was different. Just comment.
Noni McDonald from Dalhousie in Halifax. I want to go the other way around for Dr. Boivin and Chief Christian. Governments like simple solutions for complex problems, and then they get grumpy when they don't work. Mm-hmm. And we all know simple solutions aren't always the answer. So I guess the question I want to ask both of you are, what are the resiliency factors that we can be working on if you've got the wrong genetic preload when you're young? And I know some of this has to be local solutions for the local problems, but what are the factors that we can push hard on to try to make people more resilient and less likely to have these problems when they grow up, no matter what kind of genetic preload you got or, and sadly, the environment that you end up being in? And for Dr. Jha, could we do the same thing with bullets? A huge excise tax to decrease deaths?
Well, from the top of my head, I would say that maybe resilience could be built around exactly the other way around. We know, for instance, that peer influence is important at a certain point in time in terms of substance use, not necessarily abuse, but certainly use. So my guess would be teaching those kinds of skills, whereas children may resist to those kinds of influences. So I don't have the list of all the risk factors that can be turned around in a way, but you just maybe have a list of them and then try to work on the other positive aspects. So peer influence is overwhelming at some point in time during pre-adolescence, certainly. So I guess wouldn't be on that turning point, perhaps work on this.
Maybe just
That's
to continue with that question, I was wondering, Chief Christian, in your CEDAR study, you are looking at resilience as a factor around substance use. Maybe it's buffering effects. And I just wondered how you were thinking about resilience. I know at Dalhousie, Dr. Michael Unger thinks about resilience. Typically, psychologists think about it as an individual characteristic, like something that the child holds or the youth holds. But Michael Unger thinks about it more from an ecological perspective, where you look at aspects of the environment as well as the individual. And is that how you're thinking about it? Are you looking at family, community?
I guess am I on? Yes, okay. In terms of the question, and I think it's really important to understand, if you're talking about resiliency, a lot of the programs that are initiated and aimed at individuals, whether it's the child or whether it's the parents. And I think what we really need to begin to invest in is the actual family unit. And how do you actually build that unit to a point of strength again? So rather than just focusing on the child, because the system is really good at removing the child from the family. And when in fact the family needs to rebuild as a unit. And I think that's really the important, when you talk about public policy, when you talk of resiliency factors, because that's what kept us alive for thousands of years, is what we call geselten, or our relations, our interrelationship with our relatives. And so I think that's the kind of public policy, I think that if you talk of a federal government sort of, or provincial government solutions, looking at the family unit and investing in that family unit. And the other factor I would say is teaching people how to manage stress. You know, in all the work that I've done in 30, 40 years around addictions, it's stress that triggers people into an addiction, whether it's alcohol or whether it's smoking or whether it's illicit drugs. Is stress management techniques are really critical to helping people on an individual basis, but also within the family. And I think that's what resiliency really is about.
Thank you.
Thank you. Rick Riopel, McGill University. Michelle, I was struck by some of the trajectories that you talked about in your longitudinal study, particularly...
The early ones?
Yes, the early predictors, of course. Particularly the difference between alcohol and some of the other ones. And now fast forward to Prebut's discussion, and particularly the reference to Russian consumption of alcohol. And the notion there that's been currently in the news about, you know, the adoption issues, Russia, North America, and some of the behavioral issues that have been observed in these youngsters being adopted and moved, obviously has issues that Chief Wayne can comment on. But the point, to come back then, Michelle, to your observations and that specific trajectory for alcohol, and then your allusion in terms of predictors of maternal alcohol exposure, brings up obviously the question of the fetal alcohol syndrome at play in these trajectories. And I throw that out to the panel for commentary.
So your question, if I understand it, would be, would there be a link between maternal consumption of alcohol during pregnancy, say, and those trajectories that I showed on, with respect to alcohol? I don't know. So it's an empirical, the typical answer is, well, that's an empirical question, but the question is, can we have the data sets to test those kinds of hypotheses? Maybe, I don't know. I would have to go back to I don't know if we have the information, specific information about pregnancy to that. But then, if I had to guess, I would say it's the early starter that would be more likely to be affected, but that's a hypothesis that should be tested.
I guess just a follow-up question to that. So that was really interesting to see those different trajectories, and you kind of mentioned the need for thinking about those when we're designing interventions. Have there been characteristics identified that would tell us earlier on which trajectory kids are going to take?
The work to be done.
Yeah.
That's the work to be done. We do have the predictors, and we'll certainly be able to replicate. Those were taken from a different study, but we can draw, we're collecting the data, so we'll be able to replicate those and be able to look at these early predictors in terms of self-control and those aggressive behaviors and those hyperactive, impulsive, if they predict differently to these trajectories. So it's an open question still.
You had something to
I do
add
want to
there,
emphasize
Dr.
in terms of determinants of uptake of any substance abuse, the really important role of simply availability and price. The reason in Russia it's so easy to drink vodka in excess is that it's really cheap and available everywhere. You can buy, we're able to buy Yeltsin vodka in small cases on the street, which are cheaper than water. And they're sold in small units, so people don't have to put out a lot. And that, plus the social pressures that relate to collapse of societies, are really the driving factors behind really excess drinking. And men drinking in one sitting until they basically either pass out or might have an acute or a coronary event and die.
Did you have something to add, Dr.
I have a
Pfeffer?
question for those data banks where you looked at, it's kind of international comparisons. Do you have information about possible determinants and variation that you may find between countries in terms of determinants? Do you have the data banks to address those questions?
Determinants of
Determinants in
smoking
terms
or
of,
drinking?
for instance, do you have differences in terms of the links with poverty, for instance, or personal characteristics that may be measured at some point? This is probably more difficult to do. Yeah, education.
They are available, but at least in terms of smoking, the major determinants really appear to be price and also, as you alluded, peers. And now there are important exceptions which aren't well understood. And take two, for example. In the United States, male smoking between whites and blacks in the 1960s was quite comparable, or reasonably comparable. But after that, there was a big cultural shift where it became uncool in the black community to smoke, and the smoking rate substantially declined for reasons which we don't understand. In East Asia, women have not taken up smoking nearly as much as men, even with a fair amount of marketing and other efforts. I mean, aside from women being more sensible than men, we don't really know why. So there are important components of it. But if you look across countries, the main determinant of uptake and of any of these substances is price. Low price is also related to peers, because once your friends start smoking or drinking and binge, then you also take it up.
But by reducing price, what you do is to reduce it's kind of a mean difference that you're acting on the mean difference across countries. So it has a general impact, but still you will have some kids that will use more than others, and so it's a kind of different kind of determinants likely.
Eleftherios Diamandis from the University of Toronto. I have a question for Chief Christian. You mentioned that you have been in this business for about 30 years. And I wanted to ask you, have you seen any changes in the sympathy, in the level of sympathy of the central government as well as the provincial government and other organizations for the problems of the Aboriginals? Is it the same, or is it getting better, or it can still get even better than where we are now?
In British Columbia, the percentage of children in care actually has gone up. In northern British Columbia, it's something like 60 to 70% of the children in care are Aboriginal. So when you talk of sort of those issues, specifically with children, it actually has gotten worse over the years. I think in terms of the issues of addictions, what we're seeing emerge is it's much more complex than it was 20 years ago. Because alcohol was primarily the addiction of choice. Now you got meth, you got crack cocaine, you have heroin, you have a number of sort of other addictions that are, sort of emerging in our communities, even in our, sort of rural communities that are remote because of the transportation issues, like in the corridors and the main transportation a lot of our communities live along. So I think the issues are becoming much more complex, but I think the actual sort of solutions that are being generated by the communities are becoming much more effective because they're trying to create solutions in the communities. Because when you create solutions outside of our communities, they don't necessarily work. So I think that the healing and residential treatment programs, harm reduction programs are emerging. Methadone programs are becoming much more prevalent in our communities than they were 20 years ago. So they are improving on the service side of things.
Very interesting presentations from all three presenters. Thank you very much. I was struck by the dichotomy in many cases in what you said between the very individual approach and the look at individual trajectories and the social and communitarian approach. I was particularly interested, though, in the fact that, Dr. Jha, you didn't mention in relation to accessibility the dumping of cigarettes by the industrialized countries by Western countries in Asia, which has been certainly very instrumental in the rise in smoking rates, as I understand it, in Asia and South America as well. Can you comment on that?
Tobacco was already quite commonly consumed in Asia, even before the multinationals. And if you look in China, which consumes about a third of the world's cigarettes, the companies that sell them are state-owned, China Tobacco. And so Western influences are there, but basically this big shift to smoking in developing countries has already occurred. Worldwide, of the 1.3 billion smokers, how many are in Canada and the US? Well, just 44 million or so. So the smokers are already there, and that's where the market has already evolved. It is true that Western tobacco companies do bring a much more nefarious type of advertising and promotion to bear, and they particularly have been trying to get women to take up smoking in Asia, so far unsuccessfully in large numbers, but that might well change. In the same way that the Virginia Slims epidemic in the US was really a deliberate manufactured attempt by the tobacco industry to try to get women to smoke. Now, there's an easy response to that. I shouldn't say easy, but there's a response to that, which is a complete ban on advertising and promotion that governments can adopt, which would shut down one of these key tools to try to engineer more smoking.
Hi, my name is Joy Johnson, and I'm from the University of British Columbia and also the scientific director for the CIHR Institute of Gender and Health. Sprinkled throughout all the comments this morning have been comments about gender, about women's sensibility, about male factors in relation to genetic predisposition, and also around differential effects for Aboriginal women vis-a-vis engagement in the sex industry, but also in relation to the effects, for example, the Highway of Tears. And so I'm wondering across the panel if you could comment in more detail. I think that this is an issue that we need to be thinking about when we look at drug abuse. We do see differential effects for males and females in this country in terms of substances of choice, in terms of rates of use, and also in terms of effects. So I'd like to probe this a little bit more in your comments and have you just reflect on issues related to gender and their effects in relation to addictions, and gender particularly as a social determinant, which is the focus of the panel today. Thanks.
Who would like to begin?
Send me out front, right? I think the issue, and one of the things that I think in the CEDAR project and what we're uncovering is that males have a tendency not to disclose and not really talk about those kinds of issues, whether it's sexual abuse, and the actual disclosure by males is very low. So henceforth, I think in our actual study, what we're seeing is the females in this case are actually disclosing more readily the actual history in their life, what has happened to them, etc. And so I think that's kind of what we've observed, and we're trying to find a way, if you will, because we understand that the numbers could be about the same, but we don't really have the statistical data at this point. But that's part of the issue we have. And I think the other part of it, it's, I think in that whole sort of dynamic around male, female gender in addictions and how, like sex work as an example, it's listed as part of it. There's also that aspect for the males, but again, they don't disclose and talk about those kinds of issues. And so I think that's what we see, and we're trying to find a way to, to gather that data so that, the male participants can actually disclose and not feel threatened by disclosing that information. So.
In terms, I will maybe answer it through determinants. I think what the data shows is that some of the determinants of engagement in substance use and abuse, I was referring to self-control, low self-control. So if you refer to aggressive behaviors and hyperactivity, for instance, or impulsivity as components, subcomponents, it's clear that males are affected many times more than women. So I think that will have an impact in terms of a developmental impact in terms of substance use, to the extent that it's a determinant. So that's one way to comment on this. Not so sure about the peer context. The way peers influence each other during early adolescence, there may be different culture difference between girls, and that may play out differently too in terms of the impact of being acquainted with friends who smoke or drink and so on. But I'm not sure the way it goes. So.
Yeah, I think for smoking, it's the evidence has emerged: smoke like men, die like men. That's quite clear. It does vary also for the other exposures, at least in terms of binge drinking patterns. They seem to be quite different. And for oral tobacco use, which you did touch upon, women might be at greater risk. There's an important dimension also about the household uses of resources, and particularly good evidence that if you leave any discretionary money in low-income settings to men, they will use it much worse than will women. For example, much higher spending on smoking and drinking than under women's control. So, and that's an important policy implication. Our good friend Julio Frank, one of the good things he encouraged in Seguro Popular in Mexico was the cash payments that went to households for health achievements went under the control of the woman, not the man. And that actually had an important impact on what household spending patterns were. So there are public policy implications of gender. Yeah.
Thank you. I think we have time for one more question.
I'm Judith Hall, also from UBC, with a slightly different twist on the gender issue. And this is probably a comment rather than a question. I'm a geneticist, and so I think epigenetically. And the epigenetic metabolic data would say there are major transgenerational effects. That is, these are at least 3 generation effects. And so my question is really, and I doubt that you have the data, but we should start collecting the data in terms of both paternal and maternal behaviors and addictions. You can actually, using methylation, identify exposures. And so if you start to collect information about addiction, it may be possible to imply what's happened from father and mother, grandfather and grandmother. And because these are 3 generational effects and different influences on males than females, it is obviously quite complex. But in the metabolic epigenetic effects, there's no question there are 3 generational effects with different effects from grandfather to grandson. So my plea is that as we begin to start trying to tease this apart, that those histories be collected and that the epigenetic studies be done to see if you can sort it out, and that this information is then taken from the pediatrician to the internist, because seeing about the outcomes and the differences in treatment may well be transgenerational effects. So again, I don't think any of you probably have grandparental data, but I think you have to now keep that in mind as you start to sort out the genetics.